Good evening, everyone. I am Dr. Sulthan and RASHID, Assistant Professor of Pharmacology from Savitha Medical College and Hospital. Today, I am going to discuss about one important antifungal agent, Voriconazole. Let's go into the topic. Voriconazole is nothing but a triazole. It has a structure similar to the fluconazole. It has increased activity in vitro. It has an expanded spectrum and poor aqueous solubility. High fat meals, it will reduce the bioavailability of voriconazole. So the drug should be given either 1 hour before or 1 hour after the meals. Coming to the bioavailability, there's a very good oral bioavailability of 96%. Coming to the volume of distribution, it is also very high, 4.6 liters per kg, with extensive drug distribution in the tissues. Coming to the metabolism, it is metabolized by the enzymes COAP2C19 and COAP2C9. COAP3A4 also plays a limited role. It exhibits non-linear metabolism. The genetic polymorphisms in COAP2C19 can cause up to 4-fold differences in the drug exposure. Particularly in Asians, about 20% of the Asians are homozygous poor metabolizers, compared with 2% of whites and African Americans. Less than 2% of the parent drug can be discovered from the urine. In case of renal failure like azotemia, or the patient undergoing hemodialysis, the oral dose does not have to be adjusted. In case of liver disease, for example in patients with mild to moderate cirrhosis, the patient should receive the same loading dose of the voriconazole. In case of maintenance dose, it should be reduced to half. If you see the intravenous formulation of the voriconazole, it contains a compound called cyclodextrin, and this cyclodextrin is excreted by the kidney. So in case of renal failure, for example, if the creatinine clearance level, if it is less than 50 ml per minute, there will be a significant accumulation of this product, cyclodextrin will occur. So in such setting, it's better to use oral voriconazole instead of intravenous voriconazole. Since majority of the people are having polymorphisms in COAP2C19 enzyme and there is different responses of voriconazole, we have to do therapeutic drug monitoring. It should be frequently used, and we should keep the target serum concentrations between 1 and 5 milligram per liter in order to maximize the efficacy and to minimize the adverse events. So what are the therapeutic uses of voriconazole? That is very important. It is the drug of choice for the invasive aspergillosis. So it shows superior efficacy comparing to amphotericin B in the therapy of invasive aspergillosis. The survival rate is also superior in voriconazole. Voriconazole is also approved for use in esophageal candidiasis. But FDA did not approve voriconazole for the empirical therapy of neutropenic patients. In the patients with neutropenia, amphotericin B is preferred over voriconazole. FDA did not approve voriconazole for empirical therapy of neutropenic patients. But in non-neutropenic patients with candidemia, we can use voriconazole. So voriconazole is comparably efficacy and less toxic than amphotericin B, which is followed by fluconazole. So in non-neutropenic patients with candidemia, we can use voriconazole, but not in neutropenic patients. FDA did not approve it for the condition. So as a summary, voriconazole is approved for initial treatment of candidemia and as well as invasive aspergillosis, as well as for salvage therapy in patients with pseudo-Aliceria boydii or Scelosporium apiospermum and Fusarium infections. In these conditions, voriconazole can be given as a first choice. There is also positive responses in patients with cerebral fungal infections. It suggests that the drug is also penetrating the infected brain very effectively. Coming to the dose of the drug, the treatment should be initially started with IV infusion. So what is the dose? 6 mg per kg every 12 hourly for 2 doses. And it should be followed by 3 to 4 mg per kg every 12 hourly. And we have to keep in mind that the dose administered should not be faster than 3 mg per kg per hour. So as the patient improves, we can convert the intravenous infusion we can change into oral administration. We can give the oral tablets 200 mg every 12th hourly. If the patient is failing to respond to this regimen, we can increase the dose up to 300 mg every 12th hourly we can give. So what are the important adverse effects of voriconazole? Voriconazole is teratogenic in animals So it is generally contraindicated in pregnancy. This is very important to remember. And although voriconazole is well tolerated, we can also see the occasional cases of hepatotoxicity have also been reported. Therefore, we should always monitor the liver function. And voriconazole can also prolong the QT interval. So it is a significant issue in patients with other risk factors for tardive dyskinesia. So we have to be careful in such patients in giving voriconazole because it prolongs the QT interval. And transient visual as well as auditory hallucinations are more frequent after the first dose. Usually it can appear at the night, and particularly with the intravenous administration. But these symptoms will diminish with time. The patients receiving the first intravenous infusions have also reported anaphylactoid reactions. So we have to be very careful in giving this drug. Voriconazole can also produce rashes in 6% of the patients. As I told you, the cyclodextrin component of intravenous formulation can be toxic to the kidney. So the intravenous voriconazole should be used with caution in patients with renal failure patients. Now coming to drug interactions, voriconazole is metabolized as well as it also inhibits the cytochrome P2C19, 2C9 and 3A4 in the order of decreasing potency. The major metabolite of voriconazole is the voriconazole N-oxide. It also inhibits these cytochrome enzymes. So inhibitors or inducers of these cytochromes can increase as well as decrease the voriconazole concentrations respectively. And voriconazole and its major metabolite, they can also increase the plasma concentration of other drugs also which are metabolized by these enzymes. For example, the two important drugs having drug interaction with the voriconazole, one of them is sirolimus. So if you are giving voriconazole along with sirolimus, the area under the curve of sirolimus increased to 11-fold in presence of voriconazole. So co-administration should be contraindicated. And while starting voriconazole in a patient receiving 40 mg per day or more of omeprazole, proton per millimeter, the dose of omeprazole should be reduced by half. So these are the two important drug interactions we have to remember. My reference is always Goodman's and Gilman's Pharmacological Basis of Therapeutics, 13th edition. And this is a gold standard book of pharmacology, as you all know. And thank you so much for your patience listening, and kindly share my lecture to your friends. Thank you.